very good evening, ladies and gentlemen, and to everybody who's watching us live from various parts of the globe. My name is Ruben Lobo, and once again, I warmly invite you to the session which got us a lot of comments yesterday. Thank you so much for all your lovely comments, and we are back once again with Dr. Souheil Hussaini, who's going to talk on the most important topic and the topic that will always and forever be the need of the hour. Yes, we're talking about peri-implantitis. For everyone who attended Dr. Souheil's session, the last time we had it, we got so many comments, and we would sincerely like to thank you for giving us all those comments. And I'm sure you are all set for today's session as well. So for the ones who don't know Dr. Souheil, a short introduction about our speaker. Dr. Souheil completed his post-graduation in prosthodontics, TMD and implant dentistry, concurrently with a Master of Science degree in oral biology from the University of Medicine and Dentistry, New Jersey Dental School, USA. His undergraduate degree and PhD degree was from the Annamalai University, Aram Dental College and Hospital, India. He is currently holding a part-time faculty position as an adjunct faculty at the Rutgers Dental School, USA.
It's Rutgers, but go ahead. Rutgers.
Rutgers, sorry, sir. His master's research and PhD was in the field of dental implants. His private dental office is based in Dubai, where he performs implant surgeries and prosthetic treatments. He is the founder of Implant Dentistry Study Consortium, the first ADA-approved dental implant continuing education course in the Gulf and the Middle East, which is also an affiliate of the Society of International Congress of Oral Implantologists and the University of Toronto. He is the chairman of the Scientific Committee Implant Dentistry Consensus, UAE. Since 1997, his experience is exclusive in implant dentistry with most of the implant systems. He's presented lectures in USA at the Harvard University, at Pennsylvania Penn University, at the Hunan University in China, and the University of Toronto, Canada. Presenting to you, Dr. Souheil Hussaini, live once again on the topic peri-implantitis.
Thank you very much. I appreciate the introduction. Definitely, this topic is amazingly important, and probably whatever we decide and talk about today in, say, 4 years' time, 25% of what we said probably is wrong. And as years go by, we can know around 50% of what we think is correct in 8 years, it's gone. So if we look at the science that way, it's like man at work, always improving. So 16 years from today, whatever you're listening to it right now probably is not going to be helping you. But for now, the latest what we have is this, and I hope it will benefit you. The first question that comes to my mind is this peri-implantitis that we all talk about nowadays. Is it reversible? Can it go back to the way it was? Can a case on the day of implant placement, within very short time, if it reaches to that stage, can it ever go back with or without our help? This is what is the reason why we need to understand peri-implantitis. Now, also, it's very interesting for us to get used to the reasons who are responsible for peri-implantitis. It's not just a matter of when it happens, how to solve it. Also, it's important for us to know who is responsible, whether it's from the patient's point of view, from the host point of view, from the diet, from the bacteria, from the dentist's point of view, armamentarium, implant system. No matter what, it's very important for us to know the share of the responsibility is put on whom. We try to, this is the session that we have today. First, we'll talk about the responsibility of who, then we immediately jump into management. Normally, management in our culture is done at the end when we study entirely the case. We talk about management. When I read the the memory span and the first 10 minutes of any discussion is the most memorable part of retention rate in human brain. I thought, let's change that philosophy and let's put the management first. So at least you leave remembering the management, and the rest is all theory and all uh, probably has to do with the name of the bacteria and different statistics and different definitions and classifications. But the first thing is, when it happens, how you solve it. So I think that's what I wanted to focus on. All right. So because we have around 10,000 implant cases that we are uh, following with and with the statistics. So whatever I say to you is based on those 10,000 cases that we have. The name of those responsible microorganisms are good to know, but it's better also to know how do they behave and why do they show up. So we will discuss in detail on the right time that why these bacteria are there and why they do what they do. The other issue of responsibility is there is a lot of literature which discusses that peri-implantitis the main cause has two folds. One is over stress or occlusal trauma, and the other one is microorganism. In this session, my opinion is occlusal trauma has nothing to do with peri-implantitis. In this statement that I just said, I'll be contradicting maybe more than 100 articles. So there will be a lot of audience that will disagree with this, which is fine. I spent 4 years understanding what does occlusion and what does stress and how much is it does on implants. And after 4 years of research, I can confidently say that it is bacteria which is causing peri-implantitis. Occlusion always can have a contributing factor, but it cannot start with occlusion. I will not go into the detail of my 4 years of research on this. Just the bottom line is the maximum occlusal force that a human can apply is far from causing damage to the bone surrounding the implant. And to make even the story more interesting, actually it's the reverse. The lack of stimulation from occlusion can cause disuse atrophy, bone resorption, and cause for peri-implantitis. So that's why my focus in this presentation totally excludes anything to do with occlusal trauma. What we know in a good oral health, teeth and implants have similar microflora with the streptococci and non-mobile rods predominating. So we know in good oral health what is there in the mouth. The same group of recognized periodontopathogens are involved in the periodontal disease and in implantitis or infectious failure of implants. So basically, by reading those two articles, we can understand that when the ratio of these microorganisms change, then the problem starts. In other words, all these microorganisms are available in our mouth. The same thing, this is my backyard, I'm doing some gardening, and I'm looking at these, let me move this a bit. I'm looking at these two worms. There's the white kind and the brown kind. The white kind is there and the brown one is there. The white one eats all the good stuff in the garden, and the brown one contributes to the healthiness and the nourishment of the soil. So both are there together, and both are living together, the good one and the bad one. When the ratio of the white one increases, then is the time that your plant will not be able to survive, and you will lose all what you have cultivated. Okay, let us see what do we agree with. After probing death documentation, bleeding assessment, and taking peri-apical x-rays with bite registration material, so we can repeatedly repeat this every year or every 6 months or every, depends on your protocol. The supra and subgingival debridement, this is the treatment we are talking that we have consensus in our facility. So we will do probing on probing the area, and we will assess the bleeding, and the x-rays that we take every year of implant that we have doubt with will be using a bite registration material, that the x-ray will always be taken in the same angle. Otherwise, in a normal scenario, we only see these patients once a year, and we take a panoramic x-ray. But for cases that we start having doubts and we have bleeding on probing, then they go to another periapical radiograph with a bite registration. We do supra and subgingival debridement, scaling with plastic tips or titanium brushes mounted on a slow speed handpiece. Patients should use interdental brushes. Floss alone is insufficient or is not enough. Another session of debridement in 2 weeks with reevaluation and motivation of the patient to keep up the home care steps. So the evaluation of this peri-implantitis, once we diagnose as this case as being peri-implantitis, we have to see these patients every 3 months. And if they don't want to basically come to our office for debridement and following our steps, then we cannot guarantee that we can help them. So once we recognize that, we have a sign-up document that the patient has to read it carefully and sign it, that they are committed to come once every 3 months. The systemic antibiotic that we prescribe is not something with the normal dose. We only prescribe doxycycline 20 milligrams, okay, in the morning and 20 in the evening, and this can go for 6 months. So basically, if the 20 milligram is not available, in many countries it's not, we take 100 milligram and divide it into 5 doses, and the patient will take it. Because we know once you have doxycycline in low doses, how does it affect the soft tissue? Then we locally, we place chlorhexidine with hyaluronic acid and also doxycycline around the implant. We believe in low-level laser therapy, and we decontaminate the area for 10 seconds without touching the implant every 6 months, because we know the duration of decontamination, and for the bacteria basically not to build the house again, you require 6 months for them to start growing again once the area is decontaminated. And after that, if the environment is maintained, then we think of guided bone regeneration, just to fill the area so there is no room for the calculus and the bacteria and the food to go and stay there. So basically it becomes just a filling the gap kind of a protocol. So we call this a refractory protocol in our center. It costs around $1,000 in a year. The patient has to come for 6 visits. The first and the last visit is basically evaluation. So generally, the actual visit that the treatment takes place, and there is actually work around the teeth and the implants, is basically 4 hours. The procedure is examination, digital full mouth magnified photographic diagnostic photographs, panoramic radiographs, scaling periapical radiographs, probing depths, and low-level laser therapy, full mouth. The medication that the patient has to do is 20 milligrams twice a day for 6 months to 1 year. Many of the patients who have problem with their digestive system and they somehow cannot take medication, there are two homemade, or we can say local, I don't know, it's called a herbal or medication or something which is good for your digestive system. Is one is kefir, which is a extract of yogurt, and that's supposed to have a lot of healthy bacteria in it, and it's available in most of the countries. And the other one is Arabic gum. Also, I've seen it in when I was in Canada. I found it there. In UAE, of course, we have a lot. In all of the Arabic countries, even in the Western countries like Europe, I've seen it to be available. You can Google it and read about it. These two, basically, they make the gastrointestinal system alkaline, so it doesn't get affected by taking medication. And 20 milligrams does not really affect your gastrointestinal tract. Chlorhexidine, ginger gel, and tetracycline, they will be mixed and they are injected around the area which has peri-implantitis. And of course, bleeding on probing will remain our source of detecting the improvement, plus the radiograph. But radiograph cannot immediately show us improvement. It takes months for the bone to actually heal in a way that it will reflect its radio opacity. So we're going with bleeding on probing to be our judge. So we basically inject that material around the implant, and we follow that 3 days apart on the 4th day, 7th, 10th, 13th, 16th, and the 19th day. What are the decision trees that are being published in the literature? One decision tree which is very commonly used is the less than 3 millimeter, 4.5 millimeter, and more than 5 millimeter depth is what is one available, very commonly referred to diagnosis tool, how to decide what treatment to do based on what. The other one is AQT concept, which is a similar concept, but it has to do with radiology as well. So they've added a radiograph of more and less of 2 millimeter of bone loss to it to give a radiographic dimension, not only bleeding on probing alone. The third one, which is by Carl Misch, it's a little more in detail, which talks about even 7 millimeters and 4 millimeters of bone loss. So basically, it's expanding the detail of where you should intervene and how you should intervene. For us, we find the first classification to be very simple and very easy to follow. And for now, we are just sticking to that 5 millimeter rule plus bleeding on probing. Let's look at some definitions and who started even talking about this. Basically, in 1987, the term peri-implantitis was introduced, and it talked about to be regarded as a site-specific infection which yield many features in common with chronic adult periodontitis. So it was related to periodontitis, gram-negative anaerobic bacteria, particularly it talks about few of them, because today we have also different bacteria in the literature. So I'm not going to go to what exactly was mentioned in 1987 to be exactly the same as today, but my point is it was very clear that they have noticed this problem such an early stage. In the 1993, the first European workshop on periodontology, they understood that this is destructive inflammatory process affecting the soft and hard tissue around osseointegrated implants, leading to the formation of peri-implant pocket and loss of suppurative bone. So then the things became destructive, and it was clear that we have to interfere, because if you just observe it, it's going to get worse. Most of you are familiar with this name. If you haven't seen his face, this is the face of Albrechtsen. We owe a lot to this gentleman in our field. Peri-implantitis, peri-implant mucositis, and peri-implantitis are infectious disease. So he basically separated them from each other, and he mentioned that that is the early stage of the second one. One is with the soft tissue and one with the bone. Then Esposito in 1998, he started talking about the early one and the late one. And the early one is related to the surgical and the host-related factor. And this is before you restore or load the implant. And the late failure is what we are used to read in the literature. So he just divided it into early and late. Then it was very well defined that what's the difference between peri-implant mucositis and peri-implantitis. This was around 2003 where this became very clear. I have the article in the end. If you guys want, we can have a link to read the articles that I'm referring to. The third international team for implantology, they found a similar definition, and they added diagnostic parameters. They looked at the plaque, the suppuration, the bleeding and probing, and the probing depth. So basically, they give a kind of a method how to diagnose it. It was not just okay, we saw a pocket and that was it. No, they made it more practically diagnosable. And they included a diagnostic aid for this problem. There is another definition of peri-implantitis, which is a little bit different. It's retrograde. This was in 1992, where he found that sometimes you have a periapical lesion around the implant. The percentage of this is very little, and it does not coincide in any way by the peri-implantitis we are used to. The terminology peri-implantitis is added to it. I thought I should, put it in the presentation. This has totally a different etiology, and clinically it is seen in a different way, and it can progress or it cannot. It has another total philosophy that is not relevant to our main topic. So we have to identify the difference between the periapical or retrograde and the one which we deal with. So let us see, what do we understand from this definition, peri-implantitis? We understand that it begins at the coronal portion of the implant, while the apical portion of the implant maintains an osseointegrated status, resulting with a non-mobile implant until bone loss progresses to involve the complete implant surface. So if you leave it, eventually the implant is going to move. This is a home take message that we all agree with. The second one is we have a peri-implant disease There are pathogens which changes the peri-implant tissue. We have an early stage of mucositis, which is basically affecting the soft tissue first, and then we have peri-implantitis, which is affecting the bone. This is the second home take message that we can understand from this topic. Now, we have so many classifications, started in 1990 till 2014, and basically what they are trying to, we have so many classifications, because the issue is so important that to diagnose it is one thing. To be able to convince the patient that amongst your family, maybe 7 of you have implants, but you are the one who got this, the unlucky one who got this disease. So you need to read different classifications so you can communicate better to your patients and show them the literature and the photographs to describe why and how it happens, and it happened to you. And the third one is, these classifications also sometimes help you for treatment. So the classifications, even though there's so many, and I cannot go over all of them, because in the end of the day, why you are reading a classification? To be able to do what? So since we already figured out the treatment, so we are not going to go over all of them, but you can take a screenshot of this photograph and you can read all these 10 articles on your own. Some of the very basic ones that will help you to understand peri-implantitis, I will just emphasize on, which is early, moderate, and advanced. And here, the 6 millimeter became the center of the demarcation between early, moderate, and advanced. So anything less than 6 is early, and 6 and plus is moderate, and then 8 millimeter. The problem is when you talk about 8 millimeter, if your implant is 8 millimeter, then probably it's advanced. So we somehow stick to the percentage portion of the classification, which is 25%, 50%, and more than 50%. So with that, we are classifying peri-implantitis by looking at the percentage, and we are not going to go over all the 10 classifications. In the literature, bruxism has contributed to the issue. Smoking more than 10 cigarettes definitely has contributed to the issue. How come that diabetic was not a major factor? A lot. The plaque index, it did contribute a little bit to the issue. Bleeding on probing definitely helps us to understand the problem. Periodontal biotype, in some articles it did make a difference, and in some articles it did not. So basically, the more articles we read, we get to know who are the more contributing factors to the issue. And that's why we should keep on our continuing education to see what has been added to the list of the contributing factors. Now it comes to the getting to know the culprits. In this chart, you will find the bacteria which are in the mouth normally, in healthy mouth. And on the right side, the dark green is, you see them in peri-implantitis. Now, if you don't look at the minor ones, the small ones, the ones who are actually, the 4 main ones which are actually and definitely have increased are only 4. The rest are equally the same. So let's get to know these 4 culprits who are actually suddenly increase in population, which causes this problem. So if you can understand how to deal with these 4 bacteria, then you can deal with peri-implantitis. Amazingly, even Candida is one of the 4, which is very interesting to know. So basically, this bacteria has shown to be the most prevalent species in the peri-implantitis. The other ones are less in number, but once they are there, their destructive nature is such that it contributes to the bone resorption. The only thing is the last one is very difficult to detect. So you might have peri-implantitis and you cannot find the 4th one. Now, one issue is with the test that they take a biopsy or they put a swab or they take a paper point and they stick it around the implant and they test it and see the percentage. The problem with that is you in that corner, you might not see any of this. And then you say, oh, then it doesn't have all the 4 elements of peri-implantitis. And that's the problem, because some of these bacteria might not be in that corner that you tested, or some of them are very difficult to actually see, even with a simple test of microbiology. So you just because you are doing intraoral test, that doesn't mean you will find all the 4. And to make the story even more interesting, two of these 4 bacteria are supposed to be with the good guys, with the good microflora, that we need them in our daily immunity for our mouth. But the problem is when their population increases, that's the problem. I relate this to a metaphor. For example, we live in Dubai. Dubai is a safe, very safe place where I can walk 3 in the morning in the street and I have no problems. And I know there will be at least few thieves in the country or few murderers or few bad people, but their population is so well controlled that is not going to affect me. But once that population is mixed up and I have, say, instead of 0.01% thieves in the country, if I have 25% thieves in the country, then maybe I will consider walking 3 in the morning on the street. So the same thing here, even though they are part of our normal flora, but once the percentage changes, they will affect other bacteria in a negative way, and it affects us in a negative way. So what do we understand from them? We understand that between 5 to 10 years, when you have implants in your mouth, it might or it will affect around 10% of the implants. So 10% of the implants placed between 5 to 10 years will have this problem. Again, between 5 to 10 years, 18%, 18.8, say 19% of the patients will have this problem. So around, I don't know how many patients you see a year, it's a very good to keep a track of those patients, because 19% of those patients will be having peri-implantitis between 5 to 10 years, not in the early stages. The retrograde, as I said, it's very nice that it's between 1% to 9.9. So we are not including that in this discussion because they are not part of this whole explanation. And smoking is definitely contributing, poor oral hygiene, and a history of periodontitis is definitely, it's an alarm for us. not to quickly place implants when the patient has periodontitis, because there is a link between patients who have it and they will affect the implants. This is to show you the percentage of population per implant placement. So as you can see, when you look at China, they are the minimum who's receiving dental implants. When you look at Switzerland, Spain, and Brazil, 130%, which is, this is, of course, we're talking about millions here. So I wanted you to see where do you stand, which country you belong to, but the percentage of people who are placing implants in your country is important for you to know that it's always related to the percentage who are receiving implants. So sometimes you'll say in some countries, they don't have so many reports of peri-implantitis, and in other countries they have. Maybe it's their diet, maybe it's their food, maybe it's they don't smoke or they do. The other issue is maybe they don't get as many. So you cannot generalize that issue, because maybe not many people in that country actually have dental implants. That's one way to look at it. This was interesting. I saw this recently, even though this was supposed to be, the research was done 2 years ago, but it was published a few weeks ago. It's very interesting that implants is the highest practice in Dubai. That's amazingly interesting. The lowest here, it mentions 2%, which is orthodontics. But it's very interesting that the highest practice done in the country, which is 28%, is implant dentistry. I guess this is all over the world, but it's good to know where you live and what's the percentage of people who are practicing implant dentistry in your country. Of course, we had 20% are doing general dentistry. I don't want to go to other things which is happening in Dubai, but my point is a country which is receiving so much implant dentistry as a percentage of dentists working in it, hopefully they also have a protocol how to deal with peri-implantitis when it comes between 5 to 10 years. This chart explains how we were ignorant about this topic. In the year 2000, there were around 70 articles. That was the starting point to alarm us about this topic. And then for a while, it kind of slowed down to 30. So actually the percentage of people who were interested from 70 became minus 52%, less articles between year 2000 and 2005. But from 2005 to 2010, they went to 100, and then the next 5 years went to 300, until now we have, in this year, in this last 5 years, we have 530 articles published on the topic of peri-implantitis. This shows that we are really in need of understanding this. And there is any article that gets published, it's always there is a need behind it. There's a problem that the author tries to understand and helps other solve. That's why an article is written and published. So when you look between around year 2015, between 2010 2015, that was the time that we really understood that this problem is huge, and they had almost 300% increase in the authors who realized that this issue needs to be discussed. this was, I look at it as just for fun. It's very interesting. They asked doctors, what do you think is the cause of peri-implantitis? Smoking was one of them. 5% of the people said, yeah, I think smoking is causing. Nerve injury, nothing. Parafunction, 28% of the dentist population, they thought it is definitely related, 28%. Smooth versus rough implant surface contributed to 31% of the dentists thinking that can be the cause. And lack of surgeon's experience was 8% of the population. Now you can ask yourself, where do you stand? If you look at these 5 items, how do you give implantitis a percentage? Do you think smoking is causing it? Do you think parafunction is? I would be interested in knowing this after the end of my presentation. We are looking at different people who are tracing peri-implantitis and publishing articles on this topic. So basically, some people believe in doing plasty on the implant and doing laser therapy on the implant, around the implant. And some of them believe that laser therapy alone is not helpful. Plasty is needed. And some people think that plasty is not helpful. You have to combine them. So we have 3 categories of people who believe they have to be combined, and or they just have to do the plasty, or they just have to do the laser. I'm not an expert in both of them, but I have started doing a low-level laser therapy. Not when I say low-level laser therapy, I'm not talking about the one from the outside. I'm talking about actually around the implant in a dosage that can decontaminate the area. So decontamination protocol laser therapy. And I definitely have positive results. With the plasty, however, because of the powder which is created by shaving the implants, I have some bad experience with that powder, which I cannot control 100%. So in this category, we are supporting the only laser therapy in our facility. Regarding the other 26 articles, which talks about 6,500 implants, they think that 30% of the perimucositis is reversible, and this is the green card, or this is the happy ending of our presentation. So if you see these patients once a year, so 30% of these people can be reversible, and you can bring them back to where they were. And that's the reason why we think you should have a very tight control over your patients, and you should know them, and you should track them, and you should not force them, but motivate them to come back to you at least once a year. Otherwise, you might lose track. And it's good to know that between 4 years and 1 month, you are expected to have this problem started. So if you neglected the patient for the first 2-3 years, don't feel really guilty, but after 4 years, you have to call the patient, and you might be able to save their implant. So when I said that we fill up the gap with bone grafting, that reosseointegration? You cannot call that reosseointegration because it doesn't integrate the same way to the host, but growth of new bone in direct contact to the previously contaminated implant surface without an intervening band of organized connective tissue is what you get, which is good enough for it not to be rejected and it not to be a nidus for food collection. This is the end. It's a comedy, but I think we have applied this in a very scientific way. But to end this with a comedy, I think it's a very interesting thing. So prior to somebody gets caught in the street, we have something called Miranda's warning that we are familiar with. With peri-implantitis, we have added a warning in our facility, which says that this is not predictable to treat, and if you delay coming when peri-implantitis starts, you might have irreversible loss of the implant. We listen to the peri-implantitis portion of our version. This is not.
The video is not.
We repeat that. Let's repeat that.
To implant loss. In a court of law, you have the right to an attorney. If you cannot or do not appoint an attorney.
Let's hear my version.
Peri-implantitis is unpredictable to treat, and late therapeutic interventions may lead to implant loss.
And I thank you for your attention, and hopefully I have answered some of your questions, and I'm ready for any questions.
How can I differentiate between the OCC trauma and implantitis?
What's OCC? Occlusal.
That's not mentioned, doctor. I would request Dr. Katia Aldi to reframe your question and resend your question. Thank you. We move to the next question. What is the role of radiotherapy in peri-implantitis?
I have no idea. Our protocol, that's why I mentioned it in the early stages. Basically, we have 1 year protocol for them. We call it refractory. Dr. Goldberg is from Toronto, is our mentor. And we basically look at it as cleaning, cleaning, cleaning. We definitely are into the cleaning field, and the mycobacteria. The same thing with weeds in your garden when you have grass. Unless you go to the root and remove the weed, by cutting off and giving antibiotics and just bombarding the patient with systemic antibiotics, it's useless. So let's not put the patient into that. It's really unfair that we don't do our homework and we keep prescribing antibiotics to these poor patients. So we believe you have to go to the root, you have to clean it. They will come back because they have a beautiful house around the implant. It's fantastic for the growth. The environment is beautiful. The shape of it is geographically is great. So we have to clean it, and we have to slowly eliminate the bacteria from reproduction. And that requires every 3 months intervention. And we have good results when we do that.
Thank you, doctor. We move to the next question. What, according to you, is good to treat peri-implantitis? Is it lasers or are they titanium curettes?
I said, see, the shaving part of the threads is something that it's called implantoplasty. The debris that is coming from that shaving, because they're not sterile anymore, once you shave them, if they're going to stay there, they're going to be nidus for infection. That's why if you have a method by which you can shave it and you don't have any debris, which I couldn't do, then go ahead. Otherwise, you have to just clean it. Laser will clean it in a biological way, and mechanically you will clean it with brushes and scalers and different instruments to make sure that the calculus or anything that is sticking on the surface of titanium is removed.
Thank you very much, sir. We move to the next question. Peri-implantitis. Is it area specific, Dr. Souheil? Which region in oral cavity is more affected? Do we have any studies on the same?
I've never, in all these things that I've studied, it wasn't very site specific. I never went researching that point. I don't know.
Thank you, sir. Next question. Long time since I heard a beautifully scientifically crafted lecture on peri-implantitis. Thank you, Dr. Souheil. What are your experiences and successes behind managing peri-implant bone loss and the quality of bone that forms afterwards?
We are not interested in testing the first of all, to test the quality of a grafted material is very difficult, and we are not actually interested in testing it. If we can stop this disease and we can make sure it doesn't come back, and we put any material, of course we prefer 50% of autogenous with 50% of non-resorbing bone material, because we require the biology. There is another, that's another topic, how to design your augmented material, and PRF or PGRF included, to make sure the soft tissue around it is quickly formed. But we are not looking into the quality of bone. We are looking into a matrix or something to fill the gap and doesn't allow the host to suffer from a place where calculus and food can stagnate and cause peri-implantitis again.
Thank you, doctor. I move to the first question. The person who had asked the question has reframed it. How can I differentiate between occlusal trauma and implantitis?
That's what I said. I don't think we have occlusal trauma from occlusion. This is a very interesting topic, because I believe in it. 4 years, that's why I believe in this, but it's controversial to the many articles which is published today, that occlusion can cause peri-implantitis, and I'm very sure that information is not correct. How you can check? First of all, let's talk about the reverse. Under occlusion. How can you detect under occlusion? By using your basic articulating paper, and you check occlusion. So if it's under occlusion, I think it is a cause for peri-implantitis. Now, over occlusion, of course, will not make the patient comfortable to eat. So if the patient comes to you and you do the occlusal evaluation and you find this implant is in hyper position, it's your duty to basically keep it in occlusion, proper occlusion. So if the patient's other teeth are slightly mobile and you keep this implant in occlusion, as soon as the patient starts biting, the other teeth are going to basically move, and the implant is not going to move. Then the entire pressure will come on the implant, which is not good. So basically, you have to do a proper occlusal evaluation based on the mobility of the neighboring teeth, by which when the implant is being used while chewing, it's receiving an equivalent load compared to the neighboring teeth in maximum intercuspation. Thank you.
Thank you, doctor. We move to the next question. Can diseases like diabetes affect peri-implantitis?
We mentioned that. That was that article. If they go back to do they have access to see this video again?
Yes.
So kindly read that article. It will explain to you the relationship.
Any side effects after giving antibiotics just after peri-implantitis?
That's why we, in our protocol, we do not give the normal dosage. We give 1/5 of the dose, which is 20 milligram. 20 milligram doxycycline has not shown to have caused doses. And we put our patients on either kefir and Arabic gum, which makes sure that the intestine is not affected. So we have patients on 20 milligram of doxycycline for more than 1 year now, and we don't have much more than that years, and we do not have any signs. But we are not physicians. We don't know. What we know is we are stopping this disease in the mouth, and the patient's history that I'm doing fine, I feel better, I can eat on it, the sensitivity is gone. That is what we go by. And in our x-rays, if we found that the bone loss has stopped, that's what we go with. So we are not monitoring the other elements out of our reach to how is the body affected with antibiotic. What we know is 20 milligram of doxycycline per day is not causing any damages to the body if you maintain a good gastrointestinal tract healthy.
Thank you, doctor. Last question. So preferably, what type of lasers can be used for treating peri-implantitis? What are the preferred power settings?
This is a long lecture. What I recommend is you go to any of these articles. They have the setting, they have the type, they have the brand. We go with a decontaminate because we have different laser machines and different setups. So we go with decontamination. Basically, in different machines, it has a different setting. You're decontaminating the area. That's all you're doing.